Today, we're exploring trauma related disorders, an essential area of diagnosis and treatment in mental health. Trauma isn't just a single catastrophic event, it can stem from a one time incident like an assault or an accident, or prolonged stress like childhood neglect and domestic violence. At its core, trauma overwhelms a person's ability to cope, leaving lasting emotional, psychological, and physical effects. Trauma doesn't just affect the mind, it rewires the brain, disrupts emotional regulation, and contributes to anxiety, depression, addiction, and even physical symptoms. Clients may not always recognize trauma as the root cause of their distress, making accurate diagnosis a trauma informed approach essential. This lecture will cover PTSD, acute stress disorder, adjustment disorders, and prolonged grief disorder, along with the impact of trauma on the brain and nervous system. By the end, you'll be able to recognize trauma responses, differentiate diagnoses, and apply effective treatment approaches. Most importantly, we'll focus on creating a trauma informed clinical space where healing starts with feeling seen, understood, and safe. So let's get started. I don't know what happened to this slide. I feel like it cut off the top heading a little bit. That's supposed to say understanding trauma and its impact on the brain, but it just says brain, which I guess is fine. But to truly understand trauma related disorders, we need to look at what's happening in the brain and body when somebody experiences trauma. Trauma isn't just a psychological event, it rewires the brain, impacting how a person thinks, feels, and reacts long after the traumatic experience is over. So, when somebody encounters a threatening or overwhelming event, their body immediately activates the stress response system, also known as fight, flight, freeze, or fawn response. And this is controlled by the hypothalamic pituitary adrenal axis, or the HPA axis, which floods the body with stress hormones like cortisol and adrenaline, priming the body to either escape or defend itself. This response is essential for survival in the moment. But if the system remains overactivated due to repeated trauma, it can lead to chronic dysregulation where the body and the brain may stay stuck in survival mode. Several areas of the brain play a role in how trauma is processed. Starting with the amygdala, this is the brain's alarm system. It detects danger and triggers the fight or flight response. In trauma survivors, the amygdala becomes hyperactive, meaning even minor stresses can feel like major threats. The hippocampus is the region responsible for the memory formation and distinguishing between past and present threats. Trauma can cause hippocampal shrinkage, leading to problems with memory, difficulty distinguishing between real and perceived danger, and intrusive flashbacks. And then the prefrontal cortex. This is the rational decision making part of the brain that helps regulate emotions and assess risk. Trauma weakens the prefrontal cortex, making it harder for survivors to regulate emotions, control impulses, and feel safe. So, a helpful way to visualize what happens in the brain during trauma is Dr. Daniel Siegel's hand model of the brain. So, imagine your fist represents the brain. Your thumb is tucked inside the amygdala or the alarm system, and your fingers folded over it are the prefrontal cortex or that rational brain. In a calm state, these parts work together. But under stress or trauma, the prefrontal cortex flips, leaving your thumb or the amygdala in control and exposed. This is why trauma survivors often react impulsively, feeling emotionally overwhelmed or struggle to think clearly, like they have literally flipped their lid. So let's talk about some short-term and long-term effects of trauma on the brain. Short-term is increased heart rate, hypervigilance, difficulty concentrating, emotional numbness, and intrusive thoughts. These are all normal responses to trauma and may resolve with time. If trauma is repeated or unresolved, it can lead to chronic dysregulation seen in PTSD, CPTSD, and other disorders. Over time, survivors may experience persistent anxiety, mood swings, emotional detachment, memory problems, sleep disturbances, and even physical health issues like autoimmune disorders or cardiovascular disease. And trauma fundamentally changes the brain's wiring. But the good news is that healing is possible. Through therapy, mindfulness, and nervous system regulation techniques, we can help retrain the brain to move out of survival mode and back into a state of safety, connection, and resilience. So let's talk about the trauma and stress-related disorders in the DSM-5 TR and the ICD-11. So let's start with PTSD. It's one of the most well-known trauma-related disorders, but its presentation can be complex. PTSD develops after exposure to actual or threatened death, serious injury, or sexual violence. It can result from direct exposure, witnessing a trauma, learning about a trauma that happened to a close loved one, or repeated exposure to distressing details of traumatic events, such as first responders. So the core criteria for diagnosis of post-traumatic stress disorder starts with intrusions. The person re-experiences the trauma through flashbacks, nightmares, and distressing memories that feel intrusive and uncontrollable. Triggers can be anything from a sound, smell, or location that reminds them of the event. A second symptom cluster is avoidance. People with PTSD go out of their way to avoid reminders of the trauma, including places, conversations, or even thoughts related to it. This can lead to social withdrawal and emotional numbing. And then we might see negative changes in cognition and mood. And these include persistent negative beliefs about oneself or the world, difficulty feeling positive emotions, detachment from others, and a distorted blame of oneself or others related to the trauma. And lastly, hyperarousal and reactivity. So PTSD keeps that nervous system on high alert, leading to irritability, exaggerated startle response, difficulty sleeping, and hypervigilance. A person may feel constantly on edge as if danger is around every corner. For PTSD to be diagnosed, symptoms must persist for more than 1 month and cause significant distress or impairment in daily life. And then we also have some subtypes that you might want to consider. So not all PTSD looks the same. The DSM-5-TR includes 2 recognized subtypes. The first one is preschool PTSD. So this subtype applies to children under age 6 and reflects the unique ways that trauma manifests in young children. Instead of being able to articulate intrusive thoughts, children may reenact the trauma in play, have sudden behavioral regressions like bedwetting, or experience extreme separation anxiety, or become socially withdrawn. Their distress may not always seem connected to a specific memory, making diagnosis more challenging. And then we also have dissociative PTSD. So in some cases, trauma survivors experience dissociation, a state of disconnection from thoughts, emotions, or reality itself. This can include depersonalization or feeling detached from oneself as if watching from outside the body, or derealization, feeling as if the world around them isn't real. Dissociative PTSD is often linked to early, prolonged trauma and is more common in survivors of childhood abuse. So understanding these subtypes is crucial because misdiagnosis is common, especially in children, and dissociative cases where symptoms may be mistaken for mood or personality disorders. And because PTSD symptoms can overlap with many other mental health conditions, accurate diagnosis requires careful assessment. Some common disorders that share features with PTSD include generalized anxiety disorder. Both involve excessive worry and hypervigilance, but PTSD has a specific trauma-related trigger and intrusive memories. For major depressive disorder, while PTSD includes negative mood symptoms, PTSD also involves hyperarousal, avoidance, and re-experiencing symptoms which are not characteristic of depression alone. And borderline personality disorder and PTSD can both involve emotional dysregulation and impulsivity, but PTSD is rooted in trauma and often includes flashbacks and avoidance, which is not necessarily central to borderline personality disorder. But again, you can have both. And then psychotic disorders. PTSD flashbacks can appear psychotic, but individuals with PTSD retain insight and recognize that they're experiencing intrusive thoughts, unlike those with schizophrenia or other psychotic disorders. Understanding the source and nature of symptoms is key to distinguishing PTSD from those overlapping conditions. And then some additional diagnoses that we want to consider that also live within this chapter. So complex PTSD or CPTSD. So it differs from traditional PTSD in its origins and symptom presentation. While PTSD typically results from a single traumatic event, CPTSD develops from prolonged, repeated trauma, often occurring in childhood or situations of captivity such as domestic violence, human trafficking, or chronic abuse. So in addition to the core PTSD symptoms, CPTSD includes 3 additional symptom clusters: emotional dysregulation, intense mood swings, outbursts of anger or prolonged numbness, distorted self-perception, deep feelings of guilt, shame, or worthlessness, often tied to the belief that they are inherently flawed, and interpersonal difficulties, difficulty trusting others, forming close relationships, or an extreme fear of abandonment. The ICD-11 officially recognizes CPTSD as a separate diagnosis, unlike the DSM-5-TR. So if you're looking for CPTSD, you're going to look in the ICD-11. And treatment often requires longer-term therapy that integrates trauma-focused work, emotional regulation skills, and attachment-based interventions. Up next, we have acute stress disorder, which is essentially a short-term version of PTSD that occurs within the first 30 days after a traumatic event. Like PTSD, it involves intrusions, avoidance, negative mood, and hyperarousal, but it's diagnosed when symptoms last between 3 days and 1 month. Acute stress disorder symptoms develop almost immediately after trauma, whereas PTSD symptoms can emerge weeks or months later. Acute stress disorder often includes more dissociative symptoms like feeling detached from reality. And not all individuals with acute stress disorder will go on to develop PTSD. Early intervention can prevent long-term distress, but some will move on to develop PTSD. So some early interventions to prevent PTSD include grounding techniques to help manage dissociation, cognitive behavioral therapy to address early avoidance patterns, and encouraging safe emotional expression rather than suppression. Providing early support can significantly reduce the risk of PTSD. And adjustment disorders is one of the most common diagnoses in counseling. It refers to emotional or behavioral symptoms that develop in response to an identifiable stressor such as divorce, job loss, or relocation. Symptoms must begin within 3 months of the stressor and resolve within 6 months of its conclusion. Unlike PTSD, the stressor does not have to be life-threatening. Common symptoms include anxiety, depression, and difficulty coping, but do not meet the full criteria for a mood or anxiety disorder. And this chapter of the DSM also looks at prolonged grief disorder, which was recently added to the DSM-5 TR to address persistent, intense grief that interferes with daily life. Grief must last beyond 12 months for adults and 6 months for children. Symptoms include intense yearning for the deceased, identity disruption, avoidance of reminders, emotional numbness, and feelings of emptiness or meaninglessness. And it differs from major depression by its preoccupation with the specific loss rather than general hopelessness. And we also want to talk about reactive attachment disorder and disinhibited social engagement disorder. So both disorders stem from early caregiving disruptions but manifest differently. Reactive attachment disorder is emotional withdrawal, minimal seeking of comfort, and difficulty forming secure attachments. Disinhibited social engagement disorder is overly familiar behaviors with strangers, impulsivity, and lack of appropriate social boundaries. So now that we have a good understanding of the disorders at play, let's talk about the psychological and behavioral impact of trauma. Because trauma doesn't just affect memory and emotions, it reshapes how a person sees the world, themselves, and their sense of duty. It can lead to emotional dysregulation, impulse control issues, self-destructive behaviors, and difficulty maintaining relationships. Survivors often experience hypervigilance, avoidance, dissociation, or risky coping mechanisms as their nervous system stays stuck in survival mode. When trauma is prolonged or occurs early in life, that prefrontal cortex or impulse control weakens while the amygdala or fear response stays overactive. So remember flipping your lid. This makes emotions feel overwhelming and stress responses more extreme. One of my clients once described how growing up in a violent home made them feel hyper aware of their surroundings. As an adult, something as small as a partner's tone of voice could trigger an intense anger response from this client. Their body was not reacting to the present, it was responding to past danger. Through grounding techniques and breathwork, they learned to recognize early warning signs, helping them pause, regulate, and respond rather than react. So we work together to bring that lid back down to protect that thumb or the amygdala. For others, dysregulation can show up as emotional shutdown rather than anger. I had a client once describe feeling checked out during stress, struggling to engage with loved ones. For them, reconnecting meant small, manageable steps, movement, sensory grounding, and mindful social engagement. So trauma can change the way that we react in situations. It can also change a person's core beliefs about safety, trust, and self-worth. Before trauma, they may believe the world is safe, I can trust others, I'm worthy of love. After trauma, these beliefs may shift. The world is dangerous, people will betray me, I am damaged. I had a client, after experiencing multiple betrayals, begin to assume that all relationships would lead to harm. In therapy, we explored whether this belief was an absolute truth or a trauma response. Using cognitive restructuring, they learned to approach trust as a choice, not an all or nothing risk. And many trauma survivors will turn to substances, self-harm, or disordered eating to manage overwhelming emotions or emotional numbness. A client once shared that binge drinking was the only way they knew how to silence their intrusive thoughts. Instead of forcing them to just stop drinking, we first explored what pain were they trying to escape, what felt too overwhelming to sit with. Over time, sensory grounding, movement, and emotional processing helped them develop healthier distress tolerance. For another client, restrictive eating became a way to regain control after experiencing sexual trauma. Rather than focusing on food behaviors, we worked on rebuilding their relationship with their body and regaining a sense of safety within it. And let's talk about that dissociation as a trauma response. Dissociation is the brain's way of escaping when emotions become too overwhelming. It can range from zoning out to feeling detached from reality or derealization, or detached from oneself. That would be depersonalization. One client described getting into arguments with their parent and later realizing that they had no memory of what was said. It wasn't that they didn't care. Their brain was protecting them the way it had learned to in childhood. We worked on recognizing early signs of dissociation, lightheadedness, losing track of time, or feeling disconnected, and used body-based grounding. So holding cold objects, focusing on physical sensations. My favorite one is hot shower with a popsicle. And this brings them back into the present moment. So for more severe cases, the focus was on building safety first, rather than forcing reconnection. So, some key takeaways here. Emotional dysregulation isn't a choice, it's survival mode, and it worked in the past. It might just not be working now. Trauma changes how people see the world and themselves, often leading to mistrust and shame. Self destructive behaviors often serve as a coping mechanism when no other option feels available. And dissociation is the nervous system's last line of defense. Helping clients recognize it and safely reconnect is crucial. And one of the biggest breakthroughs for trauma survivors is realizing that I am not broken. My brain and body have been doing exactly what they were designed to do: survive. And from that place of understanding, healing becomes possible. A trauma informed approach to assessment is crucial in accurately diagnosing and treating trauma related disorders. Many clients may not explicitly identify their experiences as traumatic, and their symptoms may present in ways that overlap with other psychiatric conditions. A clinician's ability to recognize trauma's impact, differentiate it from other disorders, and use the right assessment tools is essential to providing appropriate care. If you're going to take testing and appraisal this summer, you'll go deeper into assessment tools, scoring, and interpretation. So for now, we'll just focus on why trauma assessment matters, common misdiagnoses, and key tools to evaluate trauma symptoms. So trauma informed care means recognizing that many clients are dealing with the effects of trauma, even if they don't name it as such. Clinicians must look beyond symptom presentation and consider whether a trauma history may be shaping the way clients experience the world and their mental health symptoms. Without a trauma informed lens, clients may receive an inaccurate diagnosis, such as anxiety disorders when their hypervigilance and avoidance is rooted in PTSD, depression when their emotional numbness and detachment stem from dissociation, borderline personality disorder when their emotional dysregulation and fear of abandonment result from complex trauma, or psychotic disorders when flashbacks and dissociative experiences are mistaken for hallucinations. Using standardized trauma assessments helps differentiate PTSD and trauma related disorders from other psychiatric conditions, ensuring accurate diagnosis and effective treatment planning. So, there are multiple evidence based tools to assess trauma exposure, PTSD symptoms, and cognitive distortions related to trauma. The first one I'm going to talk about is maybe the most popular one. It's the PTSD checklist for the DSM 5 or the PCL 5. It's a 20-item self report questionnaire assessing all 20 PTSD symptoms from the DSM 5. It can be used for screening, monitoring symptom changes during treatment, like a pre-test, post-test, and making a provisional PTSD diagnosis. So clinicians can use the total score to determine PTSD severity or assess symptom improvement over time. The second one is the CAPS 5, or the Clinician Administered PTSD Scale for DSM 5. And it's considered the gold standard for PTSD assessment. It's a structured clinical interview that provides a comprehensive assessment of PTSD symptoms, severity, and impact on functioning. It's administered by trained clinicians, researchers, or paraprofessionals with a working knowledge of PTSD. And the third one is Post-Traumatic Expectation Scale, or PTES. It's an 81-item self-report measure, so it's a lot longer than the other ones. And it assesses for dysfunctional beliefs and expectations after trauma. It's used to assess cognitive distortions about safety, trust, self-worth, and the likelihood of future trauma. And it includes a shortened 13-item version for quick screening. So some key takeaways here. Trauma symptoms can mimic other psychiatric conditions, making assessment tools essential for differential diagnosis. The PCL-5 provides a quick, structured way to screen for PTSD symptoms and track changes in symptom severity over time. The CAPS-5 is the gold standard for PTSD diagnosis, offering a clinician-led, in-depth evaluation. And the PTES helps assess trauma-related cognitive distortions, identifying areas for cognitive restructuring and treatment. So using these tools ensures that clinicians are not just recognizing symptoms, but truly understanding how trauma has shaped their clients' mental health, emotions, and worldview. Effective trauma treatment requires a combination of therapeutic approaches that addresses both the psychological and physiological impact of trauma. No single method works for everyone. Treatment must be individualized based on clients' history, symptoms, and readiness for processing. So several evidence-based therapies have been developed specifically for trauma-related disorders, each with different mechanisms of action. There's cognitive processing therapy, and it focuses on reframing trauma narratives and challenging distorted beliefs. Trauma often leads to rigid thought patterns such as, I should have done something to stop it, or the world is completely unsafe. Cognitive processing therapy helps clients identify and restructure these beliefs, reducing shame, guilt, and fear. Prolonged exposure therapy targets avoidance behaviors and hyperarousal. Many trauma survivors avoid reminders of their trauma, reinforcing fear-based responses. Prolonged exposure therapy gradually exposes clients to trauma-related memories or situations in a controlled way, helping them regain a sense of safety and reduce reactivity over time. eye movement desensitization and reprocessing, so EMDR. You've probably heard of this one before. It combines a bilateral stimulation, such as guided eye movements, with trauma recall to help the brain reprocess distressing memories. Research suggests that EMDR reduces amygdala overactivation, it strengthens that hippocampal integration of traumatic memories, and promotes adaptive emotional resolution. And schema therapy is particularly useful for clients with complex trauma and deeply ingrained maladaptive patterns. By addressing early life experiences, unmet needs, and core beliefs, schema therapy helps clients break free from self defeating cycles that have shaped their relationships and perceptions. And while therapy is the primary treatment for PTSD and trauma disorders, medications can be helpful in managing symptoms, particularly when trauma responses are overwhelming. SSRIs and SNRIs, such as Zoloft and Effexor, are first-line treatments for PTSD, particularly for chronic anxiety, depression, and emotional numbing. Prozasin is commonly prescribed to reduce trauma-related nightmares and hyperarousal. It works by blocking noradrenaline, reducing the body's fight or flight response during sleep. And there's also off-label medications such as antipsychotics, beta blockers, or mood stabilizers that can be used in cases of severe dissociation, impulsivity, or aggression, but they should be prescribed cautiously and in combination with therapy. So medication alone does not resolve trauma, but it can reduce symptom intensity to allow for more effective engagement in therapy. And for many trauma survivors, talk therapy is not enough. Trauma is stored in the body, emotions, and sensory memory, meaning that experiential therapies can be crucial for processing and healing. Art therapy, movement-based interventions like yoga therapy and drama therapy allow clients to express and process trauma nonverbally, often helping when traditional talk therapy feels too overwhelming or just not enough. Mindfulness and somatic techniques like breathwork, again, yoga, grounding exercises, can all help regulate the nervous system and increase body awareness. Trauma often disconnects individuals from physical sensations and emotions, and these practices help rebuild a sense of safety in the body. And always, we want to consider ethical and cultural considerations in every diagnosis, but especially in trauma diagnosis and treatment. So, trauma doesn't happen in a vacuum. It's shaped by culture, environment, and social context. How someone experiences, expresses, and heals from trauma depends on community support, cultural norms, and societal beliefs about mental health. Clinicians must approach trauma diagnosis and treatment with cultural humility and ethical awareness to avoid misinterpretation or harm. Different cultures express trauma in different ways. In some, distress is verbalized. In others, it may manifest as physical symptoms like chronic pain or fatigue. Western cultures often frame PTSD as an individual psychological disorder with flashbacks, hypervigilance, and emotional dysregulation. Collectivist cultures may describe trauma in relational or spiritual terms rather than a personal mental health condition. And some languages lack a direct equivalent for PTSD, so symptoms may be expressed in ways that don't fit standard diagnostic criteria. Being aware of these differences helps validate a client's lived experience rather than forcing a symptoms into Western framework. Without cultural awareness, normal trauma responses can be misinterpreted as pathology. A behavior seen as abnormal in one framework can be adaptive in another. Emotional restraint might be viewed as detachment in Western psychology, but valued in cultures that prioritize emotional control. Spiritual visions or ancestral communication could be mistaken for psychosis instead of recognized as part of a healing tradition. And distrust of authority, common in trauma survivors from marginalized communities, might be mislabeled as paranoia when it's actually a reasonable response to oppression. A trauma-informed approach requires assessing symptoms within their cultural and historical context, not just through a Western lens. And trauma disclosure is deeply personal, and for some clients, it comes with real risks. Clinicians must ensure that clients feel safe, not pressured, to share their experiences. For example, immigrant and refugee clients may fear legal consequences, deportation, or retaliation if they disclose trauma. Survivors of racial trauma may struggle to open up to therapists who don't share or acknowledge their lived experience. LGBTQ+ clients may find it difficult to discuss trauma related to rejection or discrimination if the clinician lacks affirming knowledge. Clients with medical or institutional trauma may see therapy itself as another system of power, making engagement challenging. And the goal is to create non-coercive, safe spaces where clients share when they're ready on their own terms. So, some emerging research and future directions. Trauma treatment is evolving rapidly with new discoveries in neuroscience, innovative therapies, and a growing shift towards trauma-informed care. Some of the most promising areas of research include psychedelic-assisted therapy, technological interventions, and updates to diagnostic classifications. Starting with neuroscience and trauma recovery, studies show that PTSD alters the brain, shrinking the hippocampus, overactivating the amygdala, and weakening that prefrontal cortex. New therapies are aiming to reverse these effects by promoting neuroplasticity, or that brain's ability to rewire and heal. Techniques like EMDR, mindfulness, somatic therapies, and cognitive training are showing promise in restoring emotional regulation and memory processing. And there's also research on psychedelics, and that's really gaining some momentum as potential treatments for PTSD. And again, I just kind of have to underline this here and put it in bold and maybe italics too, that a lot of these are still not legal and not FDA approved. So they might sound really cool, but again, you're not going to be quite there yet. But there's MDMA assisted therapy, and that fosters trust and emotional openness by calming the amygdala and strengthening prefrontal hippocampal connectivity. Psilocybin helps reframe traumatic memories and promote emotional resilience. And ketamine is FDA approved for depression. It's being studied for reducing dissociation in PTSD symptoms. And while these are still in clinical trials, these therapies may revolutionize trauma treatment, especially for individuals who haven't responded to traditional methods. But if we have a substance use disorder already in the mix, we would hold off on starting these. Trauma informed care is no longer limited to specialized clinics. It's becoming a standard practice in schools, hospitals, addiction treatment centers, and correctional facilities. More clinicians are being trained to recognize trauma's hidden role in mental health symptoms. The field is shifting from pathologizing trauma responses to understanding behaviors through a trauma lens. And this approach helps reduce stigma, improve treatment outcomes by focusing on safety, nervous system regulation, and empowerment. And as our understanding of trauma grows, so does the debate about how it should be classified. Complex PTSD is recognized in the ICD 11, but not yet in the DSM. Many clinicians are advocating for its inclusion. Prolonged grief disorder may need refinement to distinguish cultural expressions of grief from clinical impairment, and dissociative PTSD subtypes are being explored as either separate diagnoses or part of a continuum. These potential updates reflect a shift towards capturing the full spectrum of trauma-related conditions, so I can't wait to see what happens with the DSM-6 when it comes out. And there's one unexpected but promising intervention that I haven't talked about yet, but is really interesting to me, and it's video games, specifically Tetris. A study found that playing Tetris for 60 minutes per day after EMDR led to increased hippocampal volume, reduced PTSD, depression, and anxiety symptoms over 6 months, and disrupted memory reconsolidation, making traumatic images less intrusive. Engaging in visuospatial tasks like Tetris shortly after trauma exposure may be a simple, low-cost, low-barrier tool to support PTSD recovery. So if you don't already have Tetris downloaded on your phone as an app, download it now, start playing it, see how your brain feels after. Trauma is a full-body experience that alters the brain, nervous system, and emotional well-being. Understanding its impact, accurately diagnosing trauma-related disorders, and approaching treatment with compassion and cultural awareness are essential for ethical, effective care. A trauma-informed approach means recognizing that many clients carry trauma histories, prioritizing safety and trust, and ensuring that symptoms are not misdiagnosed. Healing doesn't just happen through words, it happens through the nervous system, requiring body-based and sensory-focused interventions. For clinicians, working with trauma is deeply meaningful but demanding. Staying informed, prioritizing self-care, and maintaining emotional resilience are necessary to prevent burnout. Even small actions like staying hydrated can support nervous system regulation and overall well-being. Healing is more than survival. It's about reclaiming safety, connection, and full sense of self. So I ask you to take care of yourself as you guide others on their healing journeys.